Okay, thank you very much for giving me the opportunity to discuss about when to switch from conventional DMARD, Pakistan's perspective. So here I want to discuss what challenges the Pakistani rheumatologists they are facing while they are treating the rheumatoid arthritis patient, and in the presence of those challenges, are we following the international standards? So first of all, I will discuss epidemiology of RA, then importance of early treatment in RA, then common tools to assess disease activity, treatment strategies, challenges to initiate modern therapies in the developing countries, results from a survey, and then recommendations. Okay, so rheumatoid arthritis is a chronic systemic inflammatory disease which predominantly affects symmetrical small joints but can also affect the large ones. Prevalence of RA worldwide is 1%, and it's an expensive disease to treat. It cost the NHS in England around £560 million. In Asia, it is 2.8 and 3.5 cases per thousand, and according to the study done by Dr. Abid Farooqi and Terence Gibson in 1997, prevalence of RA was around 1% in adult population of the northern Pakistan. So act fast, prevent disability. That means that sooner we start the treatment, higher the chance to get the remission. That means that structure changes in RA starts early, so we need to prevent the damages from the RA. There was a study which was done in which patients were divided into two groups. One was treated within 3 months, and the second group was treated with a median of 12 months. And 50% patients in group 1 achieved remission versus 15% of patients in group 2. So that means that we need to treat the patient as early as possible to prevent disability. So the common tools we use are DAS28 scores, SDI and CDI. CDI is good in a way that we can use in the clinical setting quickly. However, in DAS28 and SDI we need blood testing in order to interpret the data. These scoring systems are not like 100% accurate, and we have more accurate things to use. For example, MRI and ultrasound, they are equally sensitive. Ultrasound is good in a way that we can do multiple ultrasound in one setting. Ultrasound found to be superior in assessing disease activity as compared to composite scoring system in many studies and reviews. So you can see Doppler activity representing the synovial activity in the ultrasound, and it's a very good tool to assess the disease. So treatment strategies in RA. So first thing is the shared decision making between the rheumatologist and patient is the most important thing, because not it is only the good clinical practice, but also especially in the countries like Pakistan, patient has to bear the cost of the treatment. So he has we should tell them what's the cost, what will be the duration, and what can be the side effects. And then we start by checking the disease activity, comorbidities, and presence of poor prognostic factors, and assess how quickly disease can progress. Of course, the compliance is the most important thing, because if patient hasn't got the compliance, there is no point to start the treatment. So especially in Pakistani patient, if you ask the patient, are you taking the medicines regularly, they will say yes. But if you check in detail, then you will realize actually they take the disease modifying drug when they are in pain. So that's why they're not getting the control of their disease. So it's very important to check the compliance. When choosing the medicines, the less costly drug is preferred over more costly one, as far as they have equal efficacy and they are safe. EULAR says that if there is no improvement, if there is less than 50% improvement within 3 months, then we should add another DMARD or biological DMARD. Not achieving the target mean risk of disability, sick leaves, early retirement, and great societal cost. Now looking at the guidelines, both ACR and EULAR, both they recommend to start with the methotrexate monotherapy, and it is preferred on the dual therapy. However, we know that combination of treatment has better results, but here when the ACR and EULAR they selected this monotherapy thing, they kept in mind the cost and the side effects related to 2 or 3 DMARDs. According to the guidelines, if there is no improvement within 3 months, then we can add biological DMARD and targeted synthetic DMARDs rather to start the combination of treatment, especially if poor prognostic factors are present. So what are the poor prognostic factors? That high RA factor, high anti-CCP, high disease activity, and failure to more than 2 DMARDs. So EULAR also says that it's inequity, that in many developing countries the high cost of treatment limits the availability of modern therapies. So they recommend to use biosimilar if the cost is sufficiently low. So is it true in case of Pakistan? Is it the cost sufficiently low? No, I think it's comparable almost. It's a little bit low. So it's better to give the generic drugs if the cost there is not much of difference. Population of Pakistan is 231 million according to 2021 data, and average monthly wages data was reported at around 24,000 Pakistani rupees, and poverty line in Pakistan has been recorded by the World Bank around 40%. So 1% of family is earning for many. So it's very, very difficult for one person to get the treatment for himself if he is treating for many, if he is looking after for many people. What to do if single or combination DMARDs not helping to achieve the low disease activity? So a small survey was conducted regarding escalation of conventional DMARD to biological or targeted synthetic DMARD. Response from 19 out of 22 rheumatologists and 12 out of 20 patients were received. More than half the rheumatologists were assessing disease activity routinely in RA patient. However, small number of the rheumatologists, they were not assessing any disease activity. They are just using their clinical judgment. Almost 90% rheumatologists used DAS28 score, and additionally, they were also using, additionally 26% were also using CDI score. Among 19 rheumatologists, no one used ultrasound in their practice. Maybe it is because of the busy clinic or lack of expertise, probably, and we need to increase that. 15 out of 19 answered that they follow the international guidelines when they switch patients to biological and targeted synthetic DMARDs. 90% also check compliance before they start the treatment. More than half will add another DMARD in case methotrexate fails to achieve the treatment targets. And 42% will switch the patient to biological or targeted synthetic DMARDs. It all depends upon what are the financial circumstances and whether there is a presence of the adverse clinical signs. So what challenges do you face in Pakistan on switching the RA patient to biological or targeted synthetic DMARDs? Almost everyone, 94%, they answered financial challenges. And then patient compliance, patient fear, anxiety to start the injectable treatment, active infection, they are also major contributing factors. Next question was, what do you do for non-affording patients who qualifies for switching from conventional DMARDs to biological or targeted synthetic DMARDs. So almost more than 50% they will add another DMARD and also refer the patient to the Baitul Mal for the fundings. Some will increase the steroids, and around 42% doctors, they will arrange the donation for the patient, which is quite reassuring and quite encouraging that our doctors, they are trying their best to treat their patients, and they're taking the pain for that. There is only one rheumatologist who answered that he will give half dose of biologic or targeted synthetic DMARD. And while I worked in one of the organization, and we were giving the half dose, and interestingly that was also working. So it all depends upon the circumstances when you treat the patients. Next question was, assuming patient has been referred to the Baitul Mal to arrange the treatment, which can take up to 6 months. What do you do meanwhile? So different opinion. Somebody will increase the steroid, someone will add anti-inflammatory or DMARDs or combination of things. But here I would like to say that the Baitul Mal process and the criteria who qualifies to get the Baitul Mal treatment, the salary limit is 20,000 to 30,000. So what if somebody is earning 40,000 or 50,000? Will they be able to support their treatment? I don't think so. So criteria, I think, need to be revised. And the rheumatology treatment, especially these biologics, should be added into Sehat Insaf card so that everybody can get the benefit, because nowadays nobody can afford such expensive treatment. Around 60% will switch, add biological DMARD or target synthetic DMARD in patients who are on 3 conventional DMARDs and low dose prednisolone with low disease activity. So 60% said in order to get rid of the steroids, they will add biological target synthetic DMARDs for that. Again, it all depends on the financial status. Then there was another question that, has anybody ever started biological or targeted synthetic DMARD without even starting the patient on conventional DMARDs? And 10% said yes. And the reason behind that, either the poor prognostic factors were present, and second thing is that patient was not getting the side effect from the combination of DMARDs, and there was no affordability issue. Then 3 questions survey was sent to 22 patients and 11 responses received. Here specifically in question number 1, I didn't mention the price of the treatment. I just asked, if you are offered a treatment with skin injection every 7 days or more on the top of your existing medicine for better control of your disease, will you consider that? 45.5% said yes, and equal number said no. And the next question was, if answer is no, what's the cause? 50% prefer treatment with 2 or 3 DMARDs, and 25% thinks that injections are the last resort. That's what the thinking of our patient, that they think that if we start the injectable, then it's a last resort and no treatment will work after that. And I rather say that's a 75%, it's in the back of their mind. That's also a big hurdle to start the biological treatment, even though patient sometimes can afford their treatment. So then the next question was, if you are offered an expensive treatment, cost 20,000 to 40,000 every month to better control of your disease, will you consider that? Around 63% they said no, and 27% said yes. And there was a person who said that I already tried the injection, but it worsened my disease. So again, financial factor is a major contributing factor. So recommendation for rheumatology community in Pakistan, different rheumatologists said different things. They are as follows. There is direct need to treat patients according to the international standards. Counseling and patients' education play a vital role in the treatment. Government education, government funding, and to include the biological and targeted synthetic DMARDs in Sehat Insaf card and instant availability through Baitul Mal. Lobbying with politicians and bureaucracy. Sustainable philanthropy and society awareness, and to push pharmaceutical to lower the price of biologics and target synthetic DMARD. I think it's very, very difficult with the rising dollar price, but they are also probably bound not to reduce the price. It's very, very difficult. So in summary, early treatment of RA can prevent the disability and indirect societal cost. Treating rheumatic disease according to the international standard is a big challenge for developing countries. This decision to switch the patient from conventional DMARD should be shared between the patient and rheumatologist. That's very, very important. Financial challenges is the biggest challenge to start the modern therapies in Pakistan, while other factors like patient's compliance, anxiety, and fear to start the injectable treatment and active infections are also major contributing factors. Detailed counseling session to discuss above mentioned facts should be organized before switching the patient on conventional DMARDs. Lobbying with politicians and bureaucracy to educate government and rheumatic disease about rheumatic disease in order to improve the funding. So when we ask that when to switch the conventional DMARDs, we should always follow the international guidelines, but also consider the patient's financial status and other factors which I mentioned in my talk. Thank you.